Hello friends, today we are going to discuss about treatment-resistant schizophrenia, part 2. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about assessment of treatment-resistant schizophrenia. What do you mean by pseudo-resistance with regard to treatment-resistant schizophrenia, and also the management. Schizophrenia is a lifelong, chronic mental disorder affecting 0.8 to 1% of the world's population. It is characterized by positive symptoms, negative, affective, cognitive, and social dysfunction characterizes the schizophrenia. And of course, many researchers also add with regard to disorganization symptom as a dimension with regard to schizophrenia. Treatment-resistant schizophrenia plays a very important role with regard to burden. Treatment-resistant schizophrenia costs 3 to 11 times more than the schizophrenia patient in remission. Unfortunately, not all patients diagnosed with schizophrenia respond to antipsychotics. 30 to 35% of patients with schizophrenia do not respond to antipsychotics. That is, one third of the schizophrenia patient are treatment resistant. Let's define treatment resistance. American Psychiatric Association gave a guideline which says little or no symptomatic response to at least 2 antipsychotic trial of at least 6 weeks duration with adequate dose range has been considered. With regard to Maudsley 2015, it says failure to respond to at least 2 antipsychotics, one is second generation and other being a first generation, each trial given at least for 4 weeks. NICE guideline 2014 says lack of satisfactory clinical improvement despite sequential use of recommended dose for 6 to 8 weeks of at least 2 antipsychotics. One of them shall be second generation antipsychotics. So there are various definitions for schizophrenia. Similarly, there are various subcategories of treatment resistance. Let's look into this treatment resistant categories. If you take 100 schizophrenia patient and you start treatment, invariably 50 to 60% will respond. Remaining 40% do not respond. Hence, you will start a second antipsychotic trial. In this again, 10 to 20% will respond. That means 30 to 35% may not respond at all. In this regard, you will consider adding Clozapine. Once you start Clozapine, in the Clozapine, invariably 30% of them will respond, and leaving approximately 70% of the patient on Clozapine do not respond. Hence, we may have to add ECT. And finally, even with ECT, the patient may not respond, and it will be around 10 to 15% can be considered as treatment refractory schizophrenia, my dear friends. So, please understand, the first antipsychotics, only 60% will respond. If you add one more antipsychotic or switch over to another antipsychotic, another 10 to 20% will respond. Last 30% require Clozapine. In that, only 40 to 30% will respond. Remaining 15 to 20% may not respond, and hence we need to add ECT. And finally, 10% of the schizophrenia may not respond even for ECT also. Those are the cases we considered as treatment refractory schizophrenia. So if you look into the categories of treatment resistance, it can be considered as early onset treatment resistance, which is majority of them. That means the patient has developed schizophrenia, and as soon as you start treatment for the first antipsychotics and sequentially second antipsychotic, he will not respond. That is early onset of treatment resistance. They are 70%. Delayed onset of treatment resistance is 30 to 35%. That means here the patient will respond for antipsychotics. He will do well and he will stop medication. That means poor adherence. You will have multiple relapse and finally you will become treatment resistance. That is called as delayed onset. Third one is clozapine resistance, also considered as ultra resistance, around 20 to 15%. And finally, treatment refractory schizophrenia is 5 to 10%. That means with all available medications, clozapine, ECT, and even psychosocial treatment, the patient may not respond. They are considered as refractory schizophrenia. Let's look into the what are the assessments we have to do with regard to treatment resistant schizophrenia. First and the foremost, we need to rule out pseudo resistance. That means the patient had not received adequate dosage, adequate duration, and also proper diagnosis. Further, we need to look into whether the patient was adherent to medication or not, suboptimal dosage, suboptimal duration, whether the patient has comorbid other psychiatric condition or medical condition such as depression, substance use, anxiety disorder, OCD disorder will come in the way of remission. And notably, substance use causes severe resistance to treatment. Further, pharmacokinetics such as poor drug absorption, concomitant medication, smoking, alcohol intake, all these will play a role in pseudo resistance. Hence, we need to do thorough assessment of treatment resistant schizophrenia. You need to reassess the primary diagnosis, check whether the patient has comorbid, one more psychiatric diagnosis, whether he has comorbid personality disorder, whether the patient had poor premorbid functioning, whether the patient has any organic conditions that needs to be ruled out, assess and consider the potential for management of chronic unresolved recurrent stressor need to be checked, assess for the adherence of medication, whether the patient tolerated the medication or else he has decreased the medicine's dosage by himself. And also we need to do baseline certain scales. I'll be touching upon those scales. We need to optimize the antipsychotic what he is taking. And many a time, if you are in doubt with regard to adherence, please do consider long-acting injectables with regard to antipsychotics so that you will be sure that the patient had received adequate dosage of antipsychotics, and we need to manage medication side effects. Now let's look into the assessment of scales. Whenever we start clozapine or else when we diagnose treatment-resistant schizophrenia, we need to do baseline assessment. The assessment is not only clinical, but also structured way of assessing which scales will give you an indication whether the patient is responding, not responding, or worsening. The most commonly used scales are PANASS scale, that is positive and negative symptom scale, SANS, scale for assessment of negative symptoms, SABS, scale for the assessment of positive symptoms, CGI and S, that is clinical global impression severity rating scale, and improvement rating scale, both can be utilized. Brief psychiatric rating scale, matrices consensus cognitive battery, global assessment of functioning, and finally social and occupational functioning assessment scale. These are the commonly used scales with regard to research and also in the clinical setting, my dear friends. Now let's look into the management of treatment-resistant schizophrenia. We have limited treatment options. First one is medications. Second one is brain stimulation. Third one is psychotherapy. Now let's look into the medications. The only approved medication by FDA with regard to treatment-resistant schizophrenia is clozapine. And it is considered as a gold standard treatment for treatment-resistant schizophrenia. However, a couple of studies looked into mega dosage or else high dosage of olanzapine in patient with regard to treatment-resistant schizophrenia. Let's look into high dosage of olanzapine. A systematic review of 10 RCT studies comprising of 615 participants, which advocated more than 20 mg of olanzapine, were considered for meta-analysis. Result suggested high dose of olanzapine, 30 to 40 mg, is superior for treatment-resistant schizophrenia, or else those patients who do not tolerate clozapine, olanzapine can be considered. And with regard to second generation antipsychotics, including haloperidol and risperidone, olanzapine is considered to be superior as per this meta-analysis. The data is encouraging for using high dose of olanzapine where clozapine becomes intolerant. That means the patient has side effects. It may be sedation, it may be carditis, it may be agranulocytosis, or else the patient simply refuses, worried about WBC count becoming less. Hence, in such situation, olanzapine can be chosen for treatment-resistant schizophrenia. Now let's look into the various studies comparing antipsychotics. One of the landmark study, Samara et al., published in JAMA Psychiatry in 2016. The title of the study was Efficacy, Acceptability, and Tolerability of Antipsychotic in Treatment-Resistant Schizophrenia. A network meta-analysis was done. In this network meta-analysis, 40 blinded RCTs were included in the analysis, which comprised 5,172 participants with regard to this analysis. And when they considered 40 RCTs, relatively few RCTs were available for antipsychotics other than clozapine, haloperidol, olanzapine, and risperidones. These are the 4 drugs where clinical trials were done in maximum number. If you look at into the primary outcome, olanzapine was more effective than quetiapine, haloperidol, and sertindol. Clozapine was more effective than haloperidol and sertindol. Risperidone was more effective than sertindol, my dear friends. A pattern of superiority was noted with regard to olanzapine, clozapine, and risperidone. But results were not consistent and effect size were very small in this meta-analysis. The most surprising finding was clozapine was not significantly better than other drugs. However, many of the researchers have criticized the way the analysis was done. At the same time, the way the studies were chosen and the interpretation was criticized. And immediately, Han et al. In 2019 published in Lancet a title of the study called as Comparative Efficacy and Tolerability of 32 Oral Antipsychotics for the Acute Treatment of Adult with Multiple Episode Schizophrenia, a Systematic Review and a Network Meta-Analysis. This is one of the best article. I request the viewers to go and look into this. Han et al. Published in Lancet. This network meta-analysis of placebo-controlled head-to-head RCT comparing 32 oral antipsychotics considered 402 studies comprising of 53,463 participants. This study aimed to compare and rank the antipsychotics by quantifying information from randomized control trial. This is one of the largest study with regard to network meta-analysis. If you look at the effect size, you can see the bottom 5 important drugs: clozapine, amisulpride, zolpidem, olanzapine, risperidone, and zuclofenthiazole. These are the drugs which had maximum effect size, and they are considered to be one of the best with regard to treatment-resistant schizophrenia. Results of this network meta-analysis clearly said all antipsychotics were superior to placebo. There were minor differences with regard to efficacy of these antipsychotics. But however, antipsychotics differ more in their side effect rather than bringing remission with regard to their difference in effect. In the in the efficacy. Clozapine, amisulpride, zolpidem, olanzapine, and risperidone were significantly more efficacious for the primary outcome than the other antipsychotic. Symptom presentation, the side effect profile of the drug, cost of the drug, comorbidity dictated the choice of drug. It is not the efficacy. It is the side effect profile, the comorbidity in the patient, whether the patient is affordable with this medication. Those were the important criteria which dictated the choice of medication. Further, Siskin et al., which looked into the meta-analysis of antipsychotic medication, clearly substantiate clozapine is superior than other antipsychotics. Leshut and his colleagues demonstrated clozapine's superiority to other 14 antipsychotics by utilizing various statistical framework. And various clinicians and researchers advise clozapine because it is superior than other antipsychotics with regard to positive symptoms, negative symptoms, suicidality, violence, and improving quality life. Now the question comes, when should we start clozapine? Whether we should start early or should we delay the clozapine? In this regard, an important publication by Khan et al. In 2018 in Lancet Psychiatry, titled as Amisulpride and Olanzapine, followed by open label treatment with clozapine in first episode schizophrenia and schizophreniform disorder, a 3-phase switching study was done. This 3-phase study recruited from 27 General Hospital Psychiatry and Psychiatric Center from 14 European countries. That means it is a multicentric across nation study, predominantly from European countries. Phase 1 study, they recruited 446 patients with intention to treatment sample, gave consent to the treatment or to join the trial. 371 completed the first phase of the trial, in which amisulpride was given, and in that 56% achieved remission. Remaining patients, there are 93, entered into the phase 2 trial. Those patients who do not remit were randomized for 4 weeks of amisulpride to be continued or to switch over to olanzapine for more than 20 mg for next 6 weeks. That means phase 2 trial is a randomization to continue amisulpride or else to change over olanzapine, and it was again randomization was done. Once again the patient do not improve, they entered into the phase 3. Here the patients who were not in remission after 10 weeks, that is in phase 1 and phase 2, clozapine was given for at least 12 weeks in an open label trial. Let's look into the results of the study. The study concluded for most patients in the early stage of schizophrenia, symptomatic remission can be achieved using a simple treatment algorithm comprising the sequential administration of amisulpride and clozapine. That means this study said no need to go for the second antipsychotic. Even the first antipsychotics given for adequate duration for a period of 6 weeks and it does not show respond, switch over to clozapine. Switching over to olanzapine did not give any edge, and we just delayed giving clozapine. By giving clozapine, the patient disease burden decreases and there is higher chance of becoming remission and going into the community. Hence, this study clearly advocated for starting clozapine immediately after single antipsychotic has failed. Although it is against the current clinical guidelines recommendation, but Khan et al. Gave this important finding. Now the question comes is that it clearly says we should start clozapine early. But what are the challenges? Various studies reported that average time duration to start clozapine from diagnosing treatment resistance schizophrenia was 4 to 5 years. That means if somebody has been diagnosed as treatment-resistant schizophrenia, the time duration to start clozapine was almost 4 to 5 years. That means we are delaying the effective treatment. That means these patients were on polypharmacy. They were on high dose of single monotherapeutic medication. Polypharmacy was done. And many a time, they may not be according to the clinical guidelines. That means there was violation of protocol in various clinical and research settings. Hence, in this regard, Dode and his colleagues did a study which is published in Psychiatric Research. This study is titled as Psychiatrist Attitude Towards the Use of Clozapine in the Treatment of Refractory Schizophrenia. A nationwide survey was done. In this, 295 psychiatrists filled the questionnaire with regard to clozapine. About 53% of the psychiatrists reported initiating clozapine according to the guidelines, whereas 33% reported that they administered clozapine only after 3 or more unsuccessful antipsychotic treatments. Let's look into the various factors. The encouraging factor was availability of clozapine blood level. Regional clozapine clinic was available. Institutional care coordinator with regard to clozapine, if it is available. Computerized patients medical database and National Support Center. All these encouraged the psychiatrist to start clozapine. However, there are discouraging factors also. Side effects such as agranulocytosis, myocarditis, changes in the cardiogram, side effects like weight gain, diabetes, constipation, salivation, all these hindered prescribing clozapine to get treatment-resistant schizophrenia. To summarize about starting clozapine, my dear friends, a review of multiple countries with regard to starting clozapine in a treatment-resistant schizophrenia showed a lag period of 1 to 14 years. Reasons quoted by various studies were unable to recognize treatment resistance, side effect profile of clozapine, blood monitoring of clozapine, and many patients are not in a position to give consent. Hence, I could not start clozapine. And finally, the cost of clozapine played a crucial role in initiating clozapine. Delay in clozapine prescription was also noted in a study done by Stokes and his colleague. And especially in the early intervention schizophrenia indicated, the prescription of polypharmacy was more commoner than the clozapine for treatment-resistant schizophrenia. A significant delay in the commencement of clozapine may reflect a missed opportunity to promote recovery in the critical early phase of illness. Hence, we need to start clozapine at the earliest, my dear friends. My own experience and what do I follow is, I usually give the first antipsychotics with adequate dosage and duration of at least 4 to 6 weeks. If the patient do not respond, I will switch over to another antipsychotics from a different class for a period of 4 to 6 weeks. If the 2 antipsychotics have failed, by the end of 2 to 3 months, I do not hesitate starting clozapine after 2 trial. Now the question comes is, what should be the dose of clozapine? There was an important landmark article published by Suhas and his colleagues from NIMHANS, Bangalore. The title of the study was, Do Indian Schizophrenia Patient Require Same Amount of Clozapine or else it has to be decreased? That was the objective of the study. Hence the title of the study was, Do Indian Patient with Schizophrenia Need Half the Recommended Clozapine Dose to Achieve Therapeutic Serum Level? An exploratory study. In this study, author measured serum clozapine level in 142 patients with schizophrenia and related disorder in a tertiary center. Oral clozapine dose need to achieve therapeutic serum level of 350 nanogram per ml was considered. Let's look into the results of the study. The clozapine dose required was 40% recommended clozapine dose for Caucasian. To achieve the therapeutic clozapine level, that means we do not require higher dosage. We require just the 40%. That means the clozapine dose required in Indian patient is somewhere around 125 to 150 milligram for non-smokers, and to some of the smokers, the dosage may require 225 to 250 milligram as per this study. However, clinical practice guideline by Indian Psychiatric Society recommends up to 300 milligram if the patient do not respond. Many a time, in ultra treatment resistant schizophrenia, we may have to give clozapine up to 600 to 900 mg, my dear friends. Now, we will look into the various augmentation of antipsychotics. If the patient do not tolerate clozapine, what shall be done? If the patient has high side effect, such as sedation, salivation, constipation, and WBC count starts falling, and also comorbidities such as seizures, obesity, cancer, what should be done? Even if the patient have cardiac problems, should we start clozapine? In such a scenario, we may have to consider various other antipsychotics such as amisulpride, aripiprazole, olanzapine, risperidone, ziprasidone, and quetiapine. And of course, we can also augment with electroconvulsive therapy, psychotherapy, RTMS, or deep brain stimulation. Let's look into the electroconvulsive therapy in treatment-resistant schizophrenia. One of the landmark article by Sandeep Grover and his colleagues, published in Acta Neuropsychiatrica, the title of the study is ECT in Schizophrenia, a review of evidence. This meta-analysis of study looked into various RCTs, 6 clinical guidelines, and 5 meta-analyses. The usual indication of its use, especially with regard to ECT among patients with schizophrenia, included treatment resistance, augmentation for pharmacotherapy, to manage catatonia, suicidal behavior, severe agitation, and clozapine-resistant schizophrenia. Despite the available evidence indicates of using ECT, many of the psychiatrists were not open to use ECT. Many of the private psychiatrists worried the patient may not come back if they suggested ECT. It is beneficial to augment ECT at the earliest whenever the patient do not respond to clozapine or else 2 or more drugs of antipsychotics. In 2005, a Cochrane review identified 9 trials with regard to ECT comparing placebo and sham ECT. And they also indicated ECT is one of the important treatment component in treatment-resistant schizophrenia. Meta-analysis of 11 studies indicates that ECT augmentation causes more symptomatic improvement than antipsychotic monotherapy. But however, we need to be careful with regard to some of the side effects such as memory impairment and headache, which are temporary for a period of 2 days to 1 week. And recently, Cochrane reviewer with regard to transcranial magnetic stimulation in schizophrenia was reviewed in 2015. This meta-analysis include 22 studies with regard to usage of RTMS in treatment-resistant schizophrenia. And in this review, it was shown that RTMS is useful in auditory hallucination. But however, the evidence was not robust. Hence, the Cochrane review concluded they called for improved study design and standardization of RTMS protocol and outcome measures. But however, the same Cochrane review also said that RTMS is advantageous because of non-invasive, OPD-based treatment, and RTMS to the left temporoparietal cortex with the low frequency TMS was very helpful in hallucination, especially with regard to auditory hallucination. Even schizophrenia patient outcome research team guideline recommended RTMS for auditory hallucination. It was found to be very effective and it lasted the effect for 3 to 6 weeks. 3 to 6 days with regard to auditory hallucination being subdued with RTMS, my dear friends. At the same time, there are certain studies which looked into deep brain stimulation in schizophrenia. Here, in deep brain stimulation, it is a invasive procedure where electrodes are placed inside the brain of the two hemispheres, and they are found to be very effective in idiopathic Parkinsonism, essential tremor, and dystonia. And these DBS procedures are safe, and various researchers have been using DBS to control treatment refractory schizophrenia. They have targeted nucleus accumbens, hippocampus, globus pallidus, internal segmentum, mediodorsal thalamus, and medial septal nucleus were the target for deep brain stimulation in schizophrenia patient. Only few case reports are there and open label trial. At this point of time, DBS is still in research purpose. And as per Mental Health Care Act of 2017, my dear friends, before you do DBS, deep brain stimulation, please do take permission from Mental Health Review Board before proceeding with operation. To conclude, my dear friends, treating treatment resistant schizophrenia is a challenge for any treating physician. You need to start an antipsychotics, give for adequate dose and duration. If there is no improvement, switch over to the second antipsychotic with adequate dose and duration. If there is no improvement, then consider clozapine. Clozapine should be considered at least for, for the dosage of 150 to 300 mg for 8 to 12 weeks. If the patient do not respond or there is a delay in response, you can augment with ECT. Choice of medication in treatment-resistant schizophrenia is based upon the side effect profile, comorbidity of the patient, and also various concomitant medications play a role. Psychosocial treatment such as cognitive behavioral therapy should be considered in patients who are cooperative and who are willing to give consent with regard to psychotherapy. Early detection of treatment-resistant schizophrenia is very essential, and we need to start clozapine at the earliest, my dear friends. Thank you very much for giving your valuable time. Stay safe.